So I did my presentation on the most five common conditions for a high school setting. I just figured that's where I would be the most as I take on a new job, and then I've been more comfortable with the injuries that I've seen at the high school level. So that's what I chose to do first. Inversion ankle sprains represent about 90% of all ankle sprains. They result to the injury of the lateral ligaments. Females are usually at a higher risk, and obviously, recurrent or history of ankle sprains is going to predispose an athlete to any ankle injuries. In activities where they're running and jumping, you're going to be more predisposed to inversion ankle sprains. Of course, inversion and mechanism of injury is going to be caused by the inversion and plantar flexion. Signs and symptoms, you're going to get some pain. You might some mild pain, disability, of course. So they could limp, they could favor one side, anything like that. Weight bearing is going to be slightly impaired. They're going to be point tender, and you're going to have swelling over the ligament. But I did this one based on a grade 1 sprain, and you're not going to really have any joint laxity when you begin these tests. So a special test that I would use, I wanted to always use the Ottawa ankle rules and the percussion test just to make sure I'm not dealing with any fractures, avulsion fractures, or to make sure I'm dealing with specifically just an inversion ankle sprain and not another injury that is referring pain. So that's what I would use the Ottawa ankle rules for in the percussion, the bump test percussion. I would also use Kleiger's to rule Kleiger's and the squeeze test, the Syndesmotic squeeze test, to make sure I'm not dealing with the high ankle sprain, and make sure that I'm truly dealing with the inversion ankle sprain. Taylor tilt, I would go inversion and eversion also, just to make sure, just to rule in that it's truly an inversion ankle sprain, and just to check the other surrounding ligaments to make sure there's no true injury to anything else that I may be missing, or the athlete may not just feel because one side is more painful than the other. And then the anterior joint test as well, just to rule out. So for treatment, during the inflammation phase, obviously police, that's newer than RICE. So we're going to protect it, optimal loading, ice, compression, and elevation. I'm seeing a lot of times we use the game ready in the beginning, maybe on the no pressure or to low right when it happens, just because sometimes the extra pressure can cause pain. E-stim, just for pain in the beginning. I've seen sometimes where we start, and obviously you're not going to use Russian or anything, but we use pre-mod, and sometimes in the beginning the athletes can't take a high of its intensity when they're maybe a few days in or a weekend, just because it's so painful. So I would typically use a pre-mod or I forgot the other name for the specific type of current that is going to be, that's going to also help with swelling, to flush the swelling out. A horseshoe pad can also be used in the beginning for treatment, just to kind of help control the swelling and also provide a way for the swelling to form and flow up instead of just pulling in that one area, typically around that lateral malleolus. So I would use a horseshoe depending on how bad it is. Sometimes it's not always warranted or necessary, but if they've swollen up pretty bad in the beginning, that horseshoe can help provide some return and get that swelling out of that area. And immobilization, also, whether it's a boot, whether it's a crutch, 2 crutches, to allow the ligament to heal if they do have an impaired gait. In the repair phase, I won't say they're pain-free, but once they can handle it, some comprehensive range of motion. So whether we're using the BAPS board, whether we're doing ABCs, and typically that can be increased with a cuff weight towards the end. But that'll help work on range of motion, whether we're doing 4-way ankle bands, 4-way ankle with the TheraBands, or if we're doing with the cuff weight as they progress. Flexibility, strengthening other surrounding musculature. So whether we're doing like towel curls in the beginning or towel slides, that way we're strengthening some of the intrinsic muscles as well, and also strengthening both sides of the ankle, and not just the one that was injured, because that can lead to further injury, one side being stronger than the other. And neuromuscular control as well. So like I said, alphabet, we're doing the alphabet, we're doing 4-way ankle, we're doing the BAPS board to kind of get some of that control and get their range of motion back. And once they get up to the remodeling phase, This is more of maybe walking on your heels, doing heel walks, toe walks, doing calf raises, working on your balance. So whether we're increasing and using the Therex pad, or if we're using the Bosu ball, that way we can strengthen that muscle and also work on their balance. And then sport specific activities. So if I'm with a basketball player, maybe we're doing some basketball drills, or if I'm with a volleyball player, maybe we're doing some sort of lateral shuffling of some sort, or ladder drills, and that way we can get their feet going, but tailored specifically to their sport. Prevention and maintenance, lateral ankle sprain. Well, I feel a lot of times ankle sprains can be prevented by actually strengthening the ankle. Taping will not prevent, but it can help if you've already been injured. But seriously working on and strengthening your ankle musculature, strengthening your calf muscles. And that way it's a little easier once these injuries happen to recover. If the ankle was already weak in the beginning, it makes it a little bit harder because there was no full strength in the beginning to actually stabilize that ankle in the first place. So I really think for prevention, from a prevention standpoint, not just throwing ankle braces on and taping, but actually strengthening the ankle musculature. That way, the ankle can survive on its own, if you would. And then continuing ankle rehabilitation and after the ankle injury to just maintain some sort of program and to make sure that the ankle is still doing well, progressing well, and we're not regressing. Surgical interventions, it depends on the severity. I even seen for grade 3 ankle sprains that it could be immobilized for up to 10 days with a stirrup brace or a cast. So it truly just depends on the severity of the ankle sprain. Or I did also a sprain of the interphalangeal joint. So a lot of times athletes come in and their fingers hurt, whether it's football, basketball, they've jammed their finger. So it can include the PIP or the DIP joint. And it is, the injury can range from a minor to complete tears of those collateral ligaments, a volar tear, a volar plate tear, or an extension expansion tear. So your collateral ligaments on either side of your finger is most common in sports like I said, basketball, volleyball, and football. The mechanism of injury, the axial force is going to produce a jammed finger, and the mechanism places either a valgus or a varus stress on the interphalangeal joints. So signs and symptoms, obviously there's going to be some pain and some swelling at the involved joint. There's going to be severe point tenderness at the joint line, depending on which joint, DIP, PIP. And then you're going to have some lateral or medial instability when the joint is in about 150 degrees of flexion. So any special tests, injuries of your interphalangeal joints can be evaluated by a varus or valgus stress test. And X-ray examinations can also be used to help ruling out avulsion fractures, depending on the severity. We also want to make sure we're ruling out other injuries, and we're really focusing in on that one specific injury. And there can be multiple, but you don't want to overlook anything. So X-rays for sure for your fingers. So treatment for this type of injury as well. So again, back to that police, compression, elevation, ice, optimal loading, and protection. So protection can come from the splinting. So if it's the PIP joint, it's usually at 30 to 40 degrees of flexion for 10 days. Or if it's a DIP joint, it's usually splinting and full extension, so that can assist in the healing process. Or we can also use cryotherapy. A lot of times when you're talking about hands, we use a slush bucket. I haven't seen yet a sleeve for the game ready for your hand. So the repair phase, you want to work on restoring that full range of motion. So again, that can come from intermittent icing, where we're doing cryotherapy and exercise. So we're slush bucket for a couple of minutes, a couple of minutes. And then we're doing some range of motion exercises, or once we're out of the inflammatory phase, even using paraffin wax, and do a paraffin dip that can help loosen up the joints before we start getting into exercises. The finger wheel is a great tool, I know, in the beginning, because it's one tool that you can use to make either harder or easier, depending on how spaced out you have your hands in the wheel. That works as well. I know the putty is a great tool to use as well, whether we're doing finger extensions, finger flexion, whether we're doing abduction, adduction with the putty in between your hand, whether we're I always tell them we're making a pancake when we're spreading the putty out, or if we're rolling it back together, that's going to help that range of motion in that finger, or those fingers that have been sprained. And then doing some, you're going to reestablish neuromuscular control. Once we get to the remodeling phase, depending on how bad it is, depending on how stiff they were, and depending on how long they were mobilized, joint mobilizations could help and be beneficial. Functional activities, whether we're doing, so for a volleyball player, if we're doing some serving or some spikes or some digs, so that way they are back into their sport. If it's a basketball athlete, if we're doing some passes, if we're doing some dribbling, if we're doing some one-handed things, that way we know that the athlete is fully capable and they're getting back. And then some strengthening exercises, like I said, with the putty. I know I've seen about 3 or 4 different colors, from easy to hard, increasing the size on the finger wheel. And then even doing, I've seen even like half-pound weights. So doing weights, maybe finger curls with those. And like I said, adduction, abduction, going up on the putty, that actually strengthen those muscles in the finger. And it's really hard to prevent jammed fingers. Sometimes a ball gets thrown wrong. We're going for a pass, we're going for a rebound, a layup, or a dig, and something just happened. So I do think that teaching proper technique in the sport is going to be very, very beneficial. It's hard to prevent. And then after injury, continuing to strengthen those ligaments and not just do without it, if you would. Surgical interventions, I think those will only come from avulsion fractures. You will splint it though. And then protective check brain can be applied to either the thumb or the finger once the athlete has been cleared to go back. I've seen a lot of concussions, so I wanted to put this one on here. We know concussions are a number one injury with athletes. So 1.6 to 3.8 million cases of mild traumatic brain injuries occur in sports. And this is why one of the reasons why I chose is 63,000 concussions annually in high school sports. But I do want to know that that's just reported. I've even seen a lot of times with my clinical experiences that concussions come in days later. So this is just concussions that have been reported. So it's a widely becoming a widely publicized health concern. So the mechanism of injury, it's always about 2 or 3. So you can have a direct blow occurring to the athlete's head. It can occur when the athlete's moving head strikes a fixed object, whether it's the ground, whether it's someone else, whether it's maybe a basketball player that's going for a rebound or something and can hit the ground on impact or anything of that nature. And then acceleration, deceleration forces, and rotational forces produce a shaking of the brain within the skull. So signs and symptoms, I was reading in the principal's book, there's not specific signs and symptoms you look for, but it should include a variety of signs and symptoms. So your clinical symptoms, whether it's going to be, oh, I have a headache, or that's somatic. If you have cognitive, they're just not, they don't feel well. They feel like they're in a fog. They feel like they're in a daze. They know something is wrong. They're emotional. Physical signs, whether it's loss of consciousness, whether if they're having trouble remember, behavioral changes, whether they're irritable, if they're upset, if they're anxious, anything of that nature. Their cognitive impairment, like if they're slow to answer questions, slow to just move out of the way if somebody's talking to them, or being aware that someone's saying their name, just slowed reaction times. And if they're sleepy, or if they're having trouble falling asleep, so sleep disturbances. So it's not just one specific thing. You can't just get one signs and symptoms, and the athlete may have it may be diagnosed with a concussion, or you can have a variety of all of these. And I've seen some cases where there's just one. I've seen some cases where there's 2 and 3. So special tests. So you're always going to have your neurological exam, assessing the cranial nerves. You're always going to do your eye function test. So your Pearl, making sure they're reactive to light, your VOMS testing in all 5 domains, and just making sure the overall vision is not blurred. You're always going to do your SCAT, whether it's SCAT 3, SCAT 5, or whatever. You're always going to do your SCAT form, just to make sure. You're always going to do your symptom scores in the beginning, and even down to if they have time, if the athlete they always will come in if they're doing the impact test. I know that's what some people call it, or concussion vitals. That's where they do the online test that they do in the beginning of the year. They'll do it after it's a suspected concussions, to see where their levels have changed. And then balance tests, whether it's the Romberg test when you're on the Eric's pad and you're in a tandem stance, or you're doing the best if you have time, if they come in after or this is the next day, the best scoring system. So 2 different services, 3 different stances, double leg, single leg, tandem, and then foam or firm for your stances on that one. So all that combined is going to let you know our tests that can be used to diagnose a concussion. And I just put these on here just so to be familiar, but everyone knows what a SCAT looks like, their symptoms, how they feel, their cognitive, their memorizing, their balance, their coordination, everything like that. Then this is one thing that I know we kept on the sideline a lot of times, or even if it was just that cognitive part, the number 4, we kept that on the side, just a quick little bam, 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 okay. And then checking, like I said, VOMs and everything else with their eyes, checking cranial nerves, just to a quick diagnosis. But this is something that you might do if you have more time. Treatment. First thing for concussions, treatment is going to be different for every individual, especially the severity of the concussion or anything like that. I've always seen it's been a variety. I've always seen multiple cases where this athlete could recover fast. This athlete may be out for 2 weeks because they're still symptomatic. So it always starts with an assessment and then rest. As long as they have symptoms, they need to give their brain rest. Once they're symptom free, that's when we can begin the return to play. So that'll be steps 3 through 8. It'll progress every day. The athlete cannot progress if their symptoms come back. So they will have to repeat that same day. And I've seen athletes try to lie and say they feel better, but you can kind of tell after that 10 minutes on the first day if they're feeling a little out of it, or if it's up to 20 minutes on that second day, if they just don't feel comfortable. But you increase your exercise each day, sport-specific activities, then they'll do a non-contact practice. They'll be seen again to get medical clearance, and then they'll do a full contact, and then they're back to normal. Sometimes you have to take away screen time. They're not allowed to go to class if that makes their symptoms worse, readings, things like that. So it all depends on the athlete. And this is where one of those things where the athlete matters. You have to make sure that you take into account the athlete's symptoms that they're presenting, because every treatment is not going to be the same. So prevention, so always reporting your symptoms early, making sure your athletes are honest. And when it comes to football, making sure that coaches and athletes are adhering to proper tackling techniques. That's a big one. And try not to rush recovery, whether it's a coach rushing you or athlete rushing you. Second impact syndrome is really real, and it can really it can be detrimental to athletes. So not rushing recovery and giving yourself the full time to heal. And stressing compliance with the treatment plan. And remember that with the treatment plan is putting their safety first. This treatment is for their safety. Surgical intervention. So as I mentioned, second impact syndrome, that requires life-saving measures that have to be performed in an emergency facility. So just making sure that we're taking the time to be mindful, recognize these, and truly treat them so that we can avoid anything surgical in that matter. Contusions. I've actually seen a lot of these, whether it's basketball players, football players, and I've seen them on men and women volleyball players falling on the floor as well. So it's an iliac crest contusion and a contusion of the abdominal musculature. It often occurs in contact sports, but it can occur in non-contact sports. It's considered one of the most disabling injuries, and it's difficult to manage. Again, every athlete is different, and that contusion is truly painful. So it really is a disabling injury. And it's direct force to the unprotected iliac crest, which can cause severe pinching action to the soft tissue of the region. So the mechanism of injury obviously results from a blow to the inadequately protected iliac crest. So signs and symptoms: immediate pain or spasms, bruising, hematoma, inability to rotate your trunk or flex the thigh without pain. Special tests. So X-ray examinations are going to be warranted to rule out any fractures or epiphyseal separations. And then for treatment in the beginning, back to police, it's applied immediately to kind of help that swelling, help that bruising, help that pain. And it's intermittently maintained for 48 hours. Severe cases, you could have bed rest for 1 to 2 days, and even ice massage in the beginning can help. During the repair phase, you're going to have inflammatory agents, restoring range of motion. So whether that's single leg raises, hip extensions, things of that nature. And you can go up in that against gravity in the beginning, or you can add cuff weights. Cardio endurance, whether it's still maintaining using the ergometer, the arm bike, or if they can take it slow pace on the stationary bike just to keep their cardio endurance up. And then beginning with strengthening. So like I said, whether that's hip extensions, single leg raises, abduction, adduction, whether that's against gravity in the beginning, and then we're moving up, whether it's cuff weights, whether it's TheraBand tubing, or whether it's resistive on machines. And then once we get into the remodeling phase, we're going to increase those same specific exercises, get back into sport specific activities. So whether that's using the ladder for basketball or football for some quick movement, whether we're doing shuffles or shuttle runs, that'll help. And then plyometrics, whether we're doing box jumps, just to kind of get that loading and that fast turnover with their hip muscles, if we're getting that, if they can stand those type of movements, whether we're doing step ups, whether we're doing monster walks with TheraBands, anything like that, plyometric wise, whether we're doing alternating lunges, jumping lunges, anything like that, where we're going to get that hip into optimal range of motion and make sure they can handle that without pain and with a decent load as well. So prevention, always. I mean, everybody doesn't wear hip padding, but someone who's frequent or someone who is active a lot, maybe getting some spandex or a girdle with extra padding if the football pads aren't enough. And then making sure we educate the athletes on secondary injuries that can be caused through bruising or through a hip pointer. So whether it's eventually fractures or making sure we don't have any separations, we want to educate them on the possibility so that maybe they take it more serious of, okay, I need to make sure I have padding, especially if you want to continue to play, you don't want to sit out, you don't want to be hurt. And that, like I said, is a very painful, very, very painful injury. And surgical interventions, it always depends on the severity for this one. So lastly, ACL sprain, or a tear, I've seen so many of these. I know I'm guaranteed one or more at every site that I've been at. So obviously anterior cruciate ligament is considered to be the most serious ligament injury in the knee. Non-contact mechanisms are 80%. It's more likely to cause an ACL injury. So not all the times is it that cutting or somebody running into you. Sometimes it's just you moving on your own, and that's caused an ACL injury. And females are more likely than males to suffer non-contact ACL injuries. For the mechanism of injury, you can be injured through direct or indirect or non-contact. So the primary mechanism is going to involve an axial load with the knee close to extension, a valgus force, internal rotation of the tibia, and an adduction of the hip. So in direct contact, the athlete is usually decelerating and changing directions when they're hit. So football player pivoting, slowing down, trying to make a move, or indirect contact. It occurs concurrently with contact by another athlete to a part of the body other than the lower leg. So somebody getting tackled up top, or somebody setting a screen and them getting their knee is planted and them getting knocked over up top on the upper body. Signs and symptoms. So usually a lot of athletes will describe a pop, followed by immediate disability. They may feel like their knee is unstable or it's shifting. You're going to have rapid swelling at the joint line, which, and this is interesting too, a lot of times I've seen in ACL tears in front of me, a lot of times they do swell and then they get pain behind their knee. I always thought that was very interesting, and obviously decreased proprioception. Special tests. So anterior drawer, not the best. There wasn't many specificity and sensitivity on this one, but the Lockmans is going to be the go-to. Your pivot shift, like Dr. Hip always said, that might be the last one you want to do, just to make sure that, because after this one, they're not going to let you do anything else after that. The jerk test, and then also want to rule out PCL injuries, but sometimes you'll get false information from the PCL just because the athlete is guarding or it's painful. Like I said, sometimes it's painful even behind there. So, but I would definitely perform Lockman's pivot shift, anterior joint, and the jerk test, all of those to rule in an ACL sprain or warrant referral for them to get further imaging. So treatment, this is one of the ones where it's truly going to be dependent on the athlete. I've seen some athletes that progress through this pretty well, and I've seen some athletes after a year, they're still kind of holding on. So this is one of the things that it's truly dependent upon your athlete. So obviously police during the first 3 weeks, and this is more so after they've been surgical, or even this inflammation phase can be pre-surgery as well, because we always want to make sure that they're in a good state before they go in, so that way we're not putting them even further behind once they come out of surgery. But police during the first 3 weeks, you want to do IFC for E-stim, just for pain. The 2 different channels, pinpoint that one area all through the knee. Patella mobilizations as well can help, especially once they're fresh out of surgery. Even just weight shifting after they're out of surgery with their crutches. So weight shifting just to start loading slightly and getting them comfortable with being able to put weight on that leg after surgery. Doing quad sets, just activating that quad so that quad does not atrophy, since that's one of the that's one of the main muscles that will atrophy during this injury. So just making sure that they're still firing, doing quad sets in the beginning, and then even hip range of motion, whether we're just doing single leg raises, just to get their hip, just so we don't lose range of motion in their hip. For the repair phase, you can use ultrasound. That's going to help, once they're not as swollen, that's going to help promote blood flow to help increase a good environment for healing. E-stim also as well in the beginning. In the repair phase, so we can start helping re-educate that quad and get it firing. Increase in range of motion. So now we can actually do more with single leg raises, short arc quads, long arc quads. A lot of times these are done without weight in the beginning. This is just general, without weight in the beginning. And then increase stationary bike, depending on where they are in this. The repair phase can be a long phase, just because depending on the athlete's healing process. So when they're once they're able to move and come out of full extension, stationary bike just to get the hip moving. Arm bike, the ergometer in the beginning as well can be very, 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 very helpful with maintaining their cardio endurance. And then hamstring strengthening. So we're just doing mini squats at this point. Anything to kind of not let that extremity lose strength. And so now we're fighting post-surgically, but now we're also having to truly almost work double, because we've let those muscles fatigue out. So ergometers, maybe the stationary bike, once they're able to come out of full extension, that may be later on towards the repair phase, but we definitely want to make sure their cardio endurance is up. We make sure they're activating their quad set, short arc quads, and increasing their range of motion. That could be towel slides, heel slides. I'm not saying we're going full 90, but definitely just to start that range of motion once it's approved. Like I said, the repair phase can be a long time. Remodeling phase, so improving balance, with any jumping activities, functional activities, and running progression. So running, I know usually doesn't start till maybe about 4 to 6 months after, but whether it's the treadmill, whether it's increasing that speed and increasing that time and duration, and then we're going outside, jumping activities, whether it's of course we're going double leg first, just hopping, and then maybe we're hopping over lines, and then maybe we're going lateral, side to side. but everything, we just want to progress with those jumping activities, functional activities. So we're now doing not functional activities, but improving your balance. So maybe we're doing Bosu ball. I'm throwing a ball and the athlete is catching it on the Bosu ball, or we're getting down into a squat, and with the Bosu ball, obviously it wobbles. So now we're working on maintaining that balance on an unsteady surface. Double leg to single leg on a Therex pad. Whether it's tandem stances and in, but double leg, single leg, and then we're going tandem stance. Just to increase that balance. I've done a lot of times with athletes. I've done they're standing on a Therex pad and we have a dumbbell and we're making figure eights. That way that they're strengthening that muscle, but this weight is pulling you in different directions. And so that's going to improve your balance. So this was just generalized because, like I said, each athlete is different, especially depending on the type of graph they might have gotten. But these are just general ideas of what type of exercises or what group I would be focusing on when it comes to treatment for an ACL. Prevention, definitely want to strengthen the quadricep muscles and other musculature of the lower extremity, just because sometimes, especially I know football players that are truly dominant on one leg over the other. You kind of want to make sure they're both equally balanced. You want to make sure you have good strength in your hamstrings and your quads, and your ankle even. It's just a one chain that you want to make sure is properly strengthened so that you're not predisposing yourself to injuries. Proper equipment. So when the athletes are done, making sure that they are wearing their braces and adhering to training, and then having a proper level of conditioning. So and then obviously we know that surgery is an option, and it depends on the patient's age, the type of stress applied to the knee, and the amount of instability that's present. So this was my presentation and hope you enjoyed it.